Hello, everyone. Good evening. My name is Magdalena Dakar, and I'm Chief Executive Officer of FH Europe Foundation. Welcome to this webinar. It's actually a trilogy dedicated to the Dyslipidemia Guidelines, and I am delighted to be joined by a fantastic group of panelists. So today online with me, we have Professor Albert Wiegmann joining us from Amsterdam, and Elsie Evans, who is our community manager and ambassador program manager. So Professor Wiegmann, if you would like to shortly introduce yourself, and Elsie, if you would like to introduce yourself as well.
Thank you. Thank you for the invitation to join the webinar. Albert Wiegmann, pediatric cardiologist, Amsterdam UMC, the Netherlands, and Secretary of the Board of FH Europe Foundation, proudly Secretary and Trustee of the FH Europe Foundation.
Thank you so much, Elsie.
My name is Elsie Evans. I am part of the FH Europe Foundation Community Support, and I also live with homozygous FH, so I have a vested interest in supporting the ambassadors with that.
Thank you so much. And you see another person who is a little bit frozen, but this is on purpose. This is Professor Borge Nordesgaard from Copenhagen, Denmark, and he is the president of the European Atherosclerosis Society. Although not in person, he's very much with us online with the pre-recorded interview, which we managed to register before he went on an exciting trip to Antarctica. A few words before I invite you to watch the interview we have registered with Professor Nordesgaard. As I mentioned, this particular webinar is the first webinar in the series of Trilogy, and the purpose of creating this trilogy was to help everyone in our community understand what dyslipidemia guidelines are, and the fact that there have been two iterations, so one in 2019 and then a focused update only last year in 2025. And we want to make sure that we help everyone joining us or watching this recording to understand what guidelines are, top line, how they're being developed, who creates them, and how they're being used in daily practice, both by the clinicians, but also how they can potentially be used for advocacy or shared decision-making by patients. That doesn't, however, mean that we will go into very specific details of the guidelines, as those are extremely rich documents, and there is no expectation of layperson or every single patient to know details. It's more merely to help you understand that those things exist and how they guide clinical practice. And with that, I would like to suggest that we hit the start button and watch the interview I had the pleasure to record.
Yes, so first of all, thank you so much for the invitation. I'm more than happy to help you create this webinar.
So let's dive deeper into the topic of today's session. And the key word is definitely guidelines. Many people hear the word guidelines, but aren't really sure what it means. So when you speak to patients or public, how do you usually explain what medical guidelines are?
It's a guideline is where some experts that really know the literature very well try to get it all together and say, giving all the evidence. And there's a lot out there, and there's a lot you can be confused about. A lot of stuff is being presented at social media or just in mass media, so like not filtered. But guidelines, a lot of experts come together. They're specifically picked by some of these organizations, like the Dyslipidemia Guidelines. We come from European Atherosclerosis Society and the European Society of Cardiology, bring people in there. And then we read all the literature, and then based on that, we agree upon what is reasonable or what is wise to tell doctors and patients and the public in general, how should we prevent atherosclerotic cardiovascular disease, meaning heart attack, strokes, without doing any harm to the ones that use whatever advice we do. It can be both lifestyle, but it can also be some therapies.
So Clearly, we have experienced in our daily practice that patient, an average layperson, wouldn't necessarily know about specific guidelines, and this is why we bring this session to the public. So, in play terms, if we were to explain to a normal everyday person a little bit more in detail, so are medical guidelines the same as strict rules that doctors must follow, or are they something else? Where would you place it?
No, it's like it's the ones that know most about an area. They try to come together and say, what do we know scientifically? So it's the evidence behind it. And of course, many countries, they say also that the doctors in that country should do their best to follow the guidelines. And some countries like mine in Denmark, there's certainly some areas where if you don't follow the guidelines, then somebody from the government will come and say, well, I'm so sorry, you should have done so and so because it stands in this guideline that you should do so and so. But it's not like you get into jail if you don't follow the guidelines. It's not like that. It's the best evidence. And so advanced societies, they try to use the best evidence in medicine to guide how doctors help patients prevent disease.
That's fantastic, because we are addressing now potentially a big number of people with some of the conditions, some of the lipid disorders joining or tuning in to listen to that. So from your medical experience, would you say that the guidelines are meant to support, replace individual medical advice? Because you just said, not everyone can follow them to every letter, and we are in the era of personalized prevention, personalized medicine. Would you say that there is a bit of a margin when it comes to individual medical advice?
Of course, I mean, all the guidelines today, they're very good at saying that the guidelines is the foundation of what you should talk about with the patient, but it needs to be a doctor-patient discussion about what you actually do.
Thank you.
So I think that's the thing, but I think please feel assured that if the doctors follow the guidelines, they do the very best for the patients. And then sometimes, of course, for some reason or another, patients won't like that part or that part, but we as doctors still have to try to tell them what is the evidence.
Oh, absolutely. And I think what would be maybe helpful is to understand, again, from your perspective, what the biggest misunderstanding is that patients or the public often have about medical guidelines. Have you ever faced a situation when someone actually misunderstood what guidelines meant?
I don't know for sure. One thing I would like to say about guidelines, though, is that as I usually try to say, it is really written by experts for experts to read. So if you as a normal person read a guideline, it can be pretty complicated to understand what's in it, even for me. But whenever there's new guidelines when there's new guidelines in this area, from most countries in the world, I read the guidelines to see in the different parts of the world how do they interpret the totality of all the evidence we have, right? So I think maybe many would think that they get confused what's in the guideline, but that's why you need some medical doctors to read the guidelines and help translate it so that it is relevant for you, just you as a single person or patient.
I echo what you said, and again, this is the reason why we're having this session, to help understand that such guidelines for dyslipidemia management exist and help our community understand what's in it. So I indeed, when I first read the 2019 guidelines, I was perplexed, and I had to read it multiple times to try and understand it. So now, if we move to the next part of this discussion, again, it would be probably very helpful to our listeners to understand how guidelines are being actually developed. And you've mentioned that this is a group of experts that come together. But if you can just maybe walk us through the process from start to finish, who is involved, how many roughly experts are there to write it, and how long does it even take to write such guidelines?
Yeah, can I maybe just start with just a little bit of history? Like when you think of the European space, Then
Absolutely. I was
then-
about to ask you about it, but I think it will be very helpful for
No,
everyone
just
else to
to
understand
start.
why is it. Yeah.
So when I was a young doctor, both in the US and in Europe, guidelines started to develop. And in Europe, it was this society that I'm president for, European Atherosclerosis Society, that wrote the first ones in 1987 and later in 1988. And then in 1994, so that's quite a few years later, we joined up with the European Society of Cardiology because they started being interested in lipids and in prevention. Before that, they were mainly on just treating patients when they got sick. And this has been a very fruitful collaboration. So now, for many years and many guidelines, we have written those together with the cardiologists. So we as the society that are very interested in preventing disease as early as possible, even in children, together with the cardiologists that see the patients when they get the disease. So now, up to date, what happened is that as European Society of Cardiology is the biggest organization, it's a huge organization with all the cardiologists in all of Europe and also countries outside. They formally invite our society, European Atherosclerosis Society, to jointly with them write the guidelines on something with lipids. And then we nominate some people that sort of like the executive committee thinks are very knowledgeable within this area and also good at sort of like synthesizing all the evidence so that at least it can be understood by experts. And the cardiologists do likewise. And then we come together, a same sort of number of people from the two ones. And then up front, we decide what is the new thing, what is it that should be explained or synthesized, or you can say agreed upon what can be advised this time. And then there's a whole process where we read the literature. Sometimes there's some staff that help finding literature. Most of us experts know the literature already. And then we end up with, given what has developed since the last guideline, what new evidence has come about so that we can give some strong advice for doctors and for their patients of how best to prevent disease. There's even a process where when we have some draft recommendations, we have an anonymous vote among these maybe 20 people that's on the panel. So we vote, do we accept that this is a good advice given the evidence? And then there's a process after that where whatever we come together with is sent out for hearing among a lot of different people. So there's a whole group of people in European Atherosclerosis Society, a lot of people within the European Society of Cardiology that are allowed to comment on it, where they sort of like think, maybe this is too much advice, maybe this is too little, forth and back. And we get all these comments in, and the whole manuscript is being rewritten, taking as many of these comments into account as possible. And then we as the group come together again and say, well, can we then, because we're the final ones, the ones maybe 20, 25 people, can we still accept it with all these comments from East and West, North and South, with modifying it? And then after that, we have a final vote where we say, now, given this, where we ended up now, do we still, each of us think it's a good idea? And then there needs to be a clear majority. I mean, you can always have one and two that disagree because maybe if there's 50 different advices, maybe one or two read the literature a little bit different from some of them, right? That's okay. It's by way the majority of those that are in the consensus agree this is what we should advise. And after that comes about a final vote and things that are agreed upon, then it is published. Of course, it's completely not told to anybody before it is published. And for these guidelines, the later years, they have always presented at the European Society of Cardiology big congress, and at the same time published simultaneously in a European Heart Journal, which is the cardiologist journal, and in Atherosclerosis, which is the journal of the European Atherosclerosis Society. And then there's a whole process after that of communicating the new things. We have had many webinars and courses and things, and what you do right now, that's also part of that, trying to explain what's actually new in these updated guidelines.
Absolutely, and yet again, I probably personally did not appreciate the whole process. So it's the first time, thanks to you, I'm discovering in details how this whole collaboration and consensus is being reached between both the European Atherosclerosis Society and the European Society of Cardiology. And I think it's extremely helpful. So if you were to throw a number, is it 10, 20, 30 experts roughly who are involved together on both sides?
Yeah, it's a bit more than 10 on both sides. Yeah.
Okay.
So it's more than 20 in total. Should I say something, Lau? When the two societies nominate them up front, we are very cautious about finding people that are both very knowledgeable and so like also balanced person that would be willing to listen to other people's interpretation of the evidence, but not being bought by industry. So also we have to declare all if we do anything with industry, which it's fine to have something, but because you can also say some of the super experts are also some of the ones that industry come and ask questions. They come and ask me questions also. But I usually say what my main conflict of interest is the Danish taxpayer, because they paid all my education, they paid all my wages, and they paid by far most of my research. But that doesn't mean that I cannot talk with the people that develop new drugs for the benefit of patients. But it has to be on a very limited. You cannot be employed by a drug company, but you can be consultant and talk with them, sure. But
and that's a fantastic segue because, to the next section of this discussion around trust, independence, and transparency. And as you can appreciate, it's extremely relevant to the patients community to understand that those guidelines are being created in an independent fashion. So I really like the fact that you've mentioned that everyone who is part of such a committee needs to declare their potential conflict of interest. And I really feel that this is an important reassurance to our community to know the scrutiny behind choosing the right people and making sure that it's not being influenced. It's being very much independent and evidence-based.
Yeah. But one thing I think is important, because some people go all the way and say you can only have people writing the guidelines that has nothing to do with the companies. The problem if you do that, then you don't necessarily get the smartest one and the ones that know the most.
And again,
so,
I think
it is a balance. I mean,
yeah.
But of course, it's like I'm not so difficult because I always say exactly what I think based on the evidence, right? But there's maybe I don't know if everybody does that.
So let me ask you a cheeky question here. We talk about expertise and we talked about bringing experts from both societies. In this particular case, when we talk about the EAS and ESC guidelines, and we talked about the industry, but what about lived experience and the growth when it comes to expertise that people with lived experience bring to the table? What is your take on opening up and potentially the role of patient advocates or patient ambassadors or patient organization in contributing to such guidelines in general? Obviously, those two have already been written, but in general.
I think the lived experience and input from patient is fantastic. That is really, really important. However, the guidelines, it's pretty complicated stuff. I mean, because you have to view all the literature. So even I have to, I've been in this for 40 years, right? And I'm not completely stupid. So I even have to concentrate to sort of like view all the evidence. So maybe this is not the best place where you bring in a lot of patients and evidence base. I think it's more when it comes to the communication and the implementation of what is the guideline. So the guideline is what is the hardcore evidence? What can be advised? But in the implementation phase, of course, let's include as many patients as possible. Of course, it needs to be knowledgeable patients. So it's somebody that can also understand what does medical evidence means, which is not so easy. I train a lot of medical doctors, and even when they come up from medical school, I try to teach them how to do research and understand research. And even those have problems understanding it after having been in medical school for 6-7 years.
And I think, you very clearly explained to us what conditions need to be fulfilled for experts to come together and contribute to development of guidelines. And I think we all agree that those are fair points and respect that. And I also remark this new maybe openness to potentially move towards welcoming expert patients. So it's not is it fair enough to settle down on, it's not a definite no, it's not yet definite yes, it's somewhere in between where that knowledge and expertise brings the most value to the publication, to the guidelines. Is that something we can at least aspire to?
Oh, sure. No, but I mean, if people that don't have a lot of insight in medical research, which is complicated, it really implicates to understand it. Then you end up with a situation where guidelines is more like whatever people post on social media. And that's a big problem. We see that in some parts of the world where it's sort of like what the people communicate and think becomes the truth. And I don't think that's the benefit for people in general. People in general are much better served by somebody understand the totality of evidence and then tell that to them so that they can have a long and healthy life without being sick, which is what I work for.
So I take that as a challenge that we need to grow our expertise, and maybe this is as well an invitation for people to be more open to reading medical publications and homework for us to decipher some of that. But let's put this to rest for 1 second, because I wanted to ask you a slightly different question. What we are observing as patients community is that we have international guidelines, or for example, European guidelines, like in this particular case, and then suddenly there is an offshoot with national guidelines. What is your take on, European guidelines versus national guidelines?
I think the system in Europe is quite good. We have these overall European guidelines where there's a representative from many different countries trying to write guidelines that is good both for the most developed, the richest countries, the less developed, maybe the poorest, and different versions. But and the guidelines actually show that, because they, for example, recognize that some countries, or the whole countries, are low risk, some are medium risk, some are high risk, and some are very high risk countries. And of course, the advice you give in these different situations differ. So therefore, it is very wise that the different countries then take the European ones and sort of like, what should I say, make sure that what is particularly relevant for the population in my country is in the national guidelines. And it's also, I think in many countries, although most Europeans have access to speaking English and things, they still feel very comfortable. It's written in their own language. So the national ones are typically written in, not in English, but in whatever language is spoken in a given country. So I think the combination of the two is good. Of course, there's a fear that if it takes too long time from the European guidelines that really try to be complete up to date, what is the newest evidence, if it takes too long before they are sort of like modified or translated into a national guidelines, then things can be too old already when it comes about. But these countries that can do it, I think in my country, Denmark, many would read the European when they come, and many doctors would implement them immediately. But there's also a process of adapting it to local Danish circumstances and have it written in Danish.
And this is very helpful. And with this, we come to an end. One of the last questions that I wanted to ask you, Professor Nordarsgaard. If you were a person living with FH, HoFH, elevated Lp(a), or FCS for that matter, which guidelines would you feel are the ones that you should be feeling more comfortable with, or at least aware of as a patient?
In the entire world, the European Dyslipidemia Guidelines. Patient organization like FH Europe, I think you do a fantastic job at it, but keep doing it. Communicate that to people. And one place you can really do a lot, and you do that a lot also, influence politicians to make the right decision about how to screen and find people with diseases early on and offer good prevention. That's what you can do.
Professor Nordersgaard, I could not have wished for a better ending and for a better call to action coming from you. I want to thank you for your time, for your expertise, and for very practical advice that we will share with people joining us at this webinar today and listening after the session. Thank you so much.
Thank you for having me.
All right, then. Albert, Elsie, first impressions based on the discussion with Borge. Very quickly, Albert.
Yeah, this is great. This is helpful to value these guidelines, how they are developed, what effort was put in, and also the relief that it has to come not straight within your face, but it has to be adapted.
Thank you. Elsie?
For me, it was nice to see a more personal engagement, if you like. It's really good to identify the fact that patients need to understand things, and it's up to us to read it and to learn if that is the way we want to go. But also the fact that these are guidelines and understanding that nationally it might be different. So it was really good.
Staying with you, Elsie, I would like to ask you, prior to becoming involved with FH Europe Foundation or an ambassador, what was your prior knowledge of guidelines? And if you can maybe just help the audience understand your personal experience with living with the dyslipidemia, and then fast forward, has work together as an ambassador manager changed your perception or use of guidelines?
So in the interest of time, I'll kind of synopsis. So for me, I was diagnosed when I was 3.5. And if you want to work out my age, it's great because it was before the guidelines were written. So brilliant idea. So I had the experience, or rather my parents had the experience of having no guidelines and people just trying to find a different way of doing it. Over the years, I think there probably were guidelines, but I didn't know anything about them. We kind of just accept that what the doctor tells you is what you do. Since I've been part of FH Europe Foundation, I've had the incredible opportunity to speak with experts and on an open conversation, not a confrontational, just generally finding out about it. Now I would say that understanding the guidelines, I don't need to know it verbatim. I don't need to know every word that's in it, but it gives me an idea of what to ask for or what to check if it is available in the country that I'm in. Africa, where it originated, is obviously very different to in the UK where I am now. And it's understanding that these guidelines are evidence-based. Still some work to be done on personalizing how it is used, but we are definitely heading in the right direction.
Thank you, Elsie. And I completely agree with you that it's not necessarily critical for every single patient to know the guidelines, but probably it is very helpful to know that they exist. And with that, I wanted to ask you, Albert, a little bit more in your daily practice, because you've seen over the years many patients and many families affected with dyslipidemias. How was that discussion in the clinic with the families? Did those people, know that guidelines existed, and would it, knowing or not knowing, how has it affected the discussions?
Not that many know about guidelines. The guidelines in the past were mostly written for adults, not that many on children, because lots of research has been done in the past decades in children. So that's a development as well. But the parents contributed a lot because they have the same disorder as the child. And if they had side effects of a certain drug, and many parents talked about that side effect, it was a reason not to introduce that drug to the children. So the guidelines and the consensus developed also with the input of the generation above. And that was a great help. And the other things that the children themselves asked for, is it not available as a tablet instead of an injection, or etc., or things they experienced taking a drug. It's not only bringing better health. Sometimes they feel tired or whatever. So it's a sort of impulse to improve. And the other thing is that what Professor Noordgaard actually excellently showed is that in the past it was only about curation. Now it's more about how can we prevent that you become a patient, that you have a disorder instead of a disease. And that's that the guidelines and the consensus are more focused on that.
And we will definitely cover that topic in more detail in the upcoming 2 sessions, next week and the week after. But let me ask you something a little bit more related to your daily practice. You're based in the Netherlands. What guidelines are you using in the Netherlands? Are you using the European ones or Dutch ones?
They are practically, we are lucky that we have many drugs available and it is affordable. So the guidelines are implemented, the European guidelines are implemented in the Dutch guidelines. And that's a sort of luck that this is there. But we do know that not every country has that availability and affordability. So there is not much room between these 2 guidelines.
And with that, Elsie, you're based in the UK right now. So what guidelines are being used or inform the management of your condition? And I'm going to be again cheeky here and ask you, was there ever any situation that maybe created a bit of a dichotomy between, how you're being managed, the European guidelines, local guidelines?
I think it's important to understand from a patient perspective that, sometimes if we read something, you automatically think that these things should be available. And maybe when you haven't read and you don't understand that there's guidelines, you don't necessarily go looking for things. So after, as I say, speaking to quite a rich group of people, I've learned that there's a lot more available than necessarily people are aware of. In the UK, we follow nice guidelines generally, but I also know that there are doctors, cardiologists who actually prefer to follow the EAS guidelines when it comes to dyslipidemia. So I think it's maybe not as clear cut as that sometimes, depending on the hospital that they work in. For me, I understand better that these are not rigid rules that they have to follow, but at the same time, they are there to show through evidence that it's best practice to have certain treatments. Now, it is, from my point of view, homozygous FH is a rare condition, which means that the treatments we have is a lot more expensive than general treatments. And with that comes compromise. It's not always as easy to get both funded. And I think that's the same in pretty much all of the countries. It comes down to what is accepted financially in the different countries. I think that there has been opportunity where if, as a patient, I ask about guidelines or question something, it is sometimes seen as confrontational, and it's not supposed to be. The whole point of the guidelines and understanding these things is for us to build that bridge between the patient and the clinician to make a shared decision. At the end of the day, it's going to be my life, my treatment. And if you say to me that those 2 treatments are the best, but actually it impacts my life to the point where it's affecting how I do things, or if I go to school, then there has to be some conversation. Professor Noordgaard said that it's the best evidence and it's the best treatment, and that's where clinicians are coming from, that they want to give you that best, but it also needs to be an understanding of what is practical for the person who lives with it.
Yeah. And I can see that our exchange now is as well promoting discussion in the chat. And just very quickly, Elsie, just building on what you said, how much is enough, or what's the minimum for patients you would now say from your lived experience is to know, to help self-advocate, to help stand up for yourself, or maybe in more positive context, have shared decision-making and informed discussion. And I appreciate you shared a very personal element here that sometimes it might be perceived as confrontational. And you're not necessarily the first person from whom we hear that, when they were trying to say, I've read it in the guidelines and engage in a discussion, it was not always welcomed. But going back to the original question, how much is enough in your opinion?
So I think there's different layers to how people see it. If you're a patient who has to, or a caregiver who has to have the treatment or find anything, I think at least understanding that the guidelines are there and where they come from, the fact that they are evidence-based and they are supposed to be best practice, but understanding that local guidelines might override some of it because of different stakeholders that are involved, whether it's politics or whether it's being able to fund it. There's all kinds of things. I think if you are going to advocate, you need to at least have read through them. You might not understand all of it, but if you read through it, you'll be able to have that conversation, or at least understand when somebody mentions something in it, and you'll be able to use that then to say, actually, no, in these guidelines, I can't tell you exactly which page, but it says that this is something we have to consider. So I think as ambassador, you need to understand the guidelines and know where they are. As I say, you don't have to know it inside out, but at least know where to point things to. As a patient, you need to understand where your treatment therapies are coming from and where the clinicians are coming from. But it's the point that you said about it being confrontational. I think it's a great time for the platform to change, where you can have a conversation with a clinician about what you understand. And there are some of them that I've had conversations with, and we have a great, very rich conversation about what the therapies are, how they impact people, what is perceived as, impact and what is real impact. And it's a nice way to be able to have an honest discussion and then a shared decision. It's, not being judged because you are asking for something different, but at the same time for patients, I think we also need to make sure that the clinician understand that we are not fighting against them. We are trying to help so that we can get the best practice for what we can actually do as well.
And on that note, let me flip now and ask Albert, in your practice, what would be a sort of a perfect patient from where you sit? How much information would be helpful for the patient to know before they come to you? And how would you react? And we know that you're always very, very sweet and very kind, but how would you react to someone who actually has got the knowledge of guidelines and maybe challenges some of your decisions?
Yes, then I think that's good for all specialists. If you are encouraged to know more about your disorder. So I think an opening sentence for every patient can be, dear doctor, you encouraged me to read more about my disorder. So I read this and this and this. So then it's a positive way of communication instead of you're completely wrong. This is the rule. But it's fun to have these types of conversations, and of course you can't always talk about everything at every moment, but at least these openings need to be there and are there.
And with that, Albert, I have great news for you. We have shared in the chat links to the Dyslipidemia Guidelines. They will be reshared in the next sessions, but there have been questions about the Dutch version of the Dyslipidemia Guidelines. So I think we can say that you will share it with us, and we will share it with the community in a follow-up, and we know who to look for because those are some of our ambassadors. So it's great to see that already this session creates reactions, and there are some fantastic suggestions as well coming from the ambassadors online, suggesting for FH Europe to maybe help decipher and make lay summary of the guidelines. And I know that our scientific communications manager is on this session as well. So Marina, some follow-up work for us too. We have covered already the topics of using, the area of using the guidelines without damaging maybe the doctor-patient relationship. So with that, I will have one difficult question. If the guidelines say yes, but the access in the country says no, How do you deal with that, Albert? And how do you deal with that, Elsie?
If it is a yes and the country says no, there is a great need of joining patients and doctors to talk to the government and to insurance companies, because then there has to be an opening for next steps. I can imagine it's not always that you have all the abilities that are there available and affordable. But if it's really important, we need to talk. And I also thank FH Europe Foundation, because they made it clear that politicians and insurance companies, as pharma is, we have to talk to pharma as well. So I think, but that's more for politicians to talk to pharma. Is that price the real price, or can we have other price that is affordable for other countries? But that's the start. I think in the next webinars, it's interesting to dive into deep, but it's an opportunity.
And I am happy for you to see that medical guidelines offer opportunities beyond management, and this is an opportunity as well for advocacy. And I didn't intend to give any answer for you, Elsie, but hey, what would be your take?
We'll get started on that then, shall we? So yes, I think the guideline, so my history in South Africa teaches me that reimbursement is a big part of whether people get the right treatment or not. And unfortunately, we know that those countries in Africa, whatever, still struggle to get the right treatment at the right cost, because it's so different. Even in the UK, it can be a postcode lottery, because it depends on whether you're close enough to a apheresis centre, whether you're not. So there's lots of things that play with it. I think it is very good for us to understand the guidelines. So having that as this is the best practice, supposedly, or, in that moment until new kind of things come up. I think it's a good tool to be able to use, to be able to go and advocate, whether it is the HTAs or whether it's politics that is stopping it from happening, or if it's individual access. It's a strong evidence-based background to go, actually, everybody, all the experts have said, this is what is needed. So if this is what is needed for my child, for me, for my community, let's work out why is it that we're not getting it? Can we overcome those? Can we build bridges around it? But so for me, the guidelines is a very good tool to use for that.
Thank you so much, Elsie, and thank you so much, Albert. I appreciate that we are nearing the end of the planned time, but I would not want to take away the opportunity from our community who is very active in the chat. So, guys listening in, one last question, final takeaway, and I'm asking everyone right now. If someone remembers just one thing from today's webinar, what should it be? And I would love to hear from you, Albert. What do you think people should remember? Elsie, what you think people should remember? And those listening in, depending on who you might represent, whether you are an ambassador, a patient, a caregiver, or maybe a medical person or industry representative, please put in the chat, what will you take away from this session? Albert.
At first, the existence of that there are guidelines and consensus papers. The other thing is that you have to know that there are developments, and they go really rapidly in pediatrics at least, but I think in many other fields as well. So, and that a doctor can deviate from a protocol if it's motivated. So you have the possibility to say, yeah, but in your case, it's different, and for that and that reason. So then it's really tailor-made. That's, I think, what's the message from this first part, the trilogy.
Thank you so much, Elsie.
For me, I think the main thing for people to take away is the fact that the guidelines exist because they are supposed to give us the best outcomes, that we build the bridge between the clinician and the patient so that it's a positive conversation, not a confrontation and a tussle to get the best out of it, but to make it definitely more precise for the person who's sitting in front of them.
Thank you so much. And I can see that there are answers coming up in the chat. Some of them are very straightforward. Others are interesting questions. Patsy, before I publicly answer, I would like to inform myself a little bit better. But I think the importance of this webinar is to help everyone understand what guidelines are, that they exist for our community, that they can inform, they can help. And as Elsie said, and it's one of my favorite statements, they help build bridges that also offers an informed shared decision making, as Albert mentioned. And I think should there ever arise any conflict, I would definitely follow the official protocols, and maybe this is something that we can make a topic for another webinar. But with that, I would like to ask, being very mindful of time as we have 1 minute to go, are there any pressing comments or questions from the public, while I ask our team to share the last slides that we have, inviting you to come to the sessions next week and the week after. So next Thursday evening, together with Dr. Julia Brandt, we will dive deeper into the 2019 dyslipidemia guidelines. And really, it's extremely important to understand the guidelines from 2019, because the update from 2025 is building on the guidelines from 2019. So without knowing the 2019 ones, 25 guidelines, the update is not sufficient. There's a lot of information in the original document. And Dr. Julia Brandt will be joined by our ambassadors, by NIE from Germany, originally from India, and Dr. Antonio Gallo from France. And the discussion will be moderated by our team member, Dr. Marina Leroy. And the final session will be moderated by our very own Elsie Evans. Give her lots of love in the chat, because she did such a great job today. And on her panel, she will have two experts representing the medical side and a patient expert, Helga Davidson, living with FCS. And on the expert side, Professor Janine Roosjes van Lennep, who was actually one of the authors of the focused update, and Professor Florian Cronenberg, who as well published an editorial on the update. I would like to thank our fantastic speakers, fantastic panelists, and I would like to thank the European Atherosclerosis Society for endorsing the Trilogy and helping us bring that knowledge to you. With that, then, I consider that we can finish this session. So thank you, everyone. Have a lovely evening. All the best. Thank you so much.